Myeloproliferative neoplasm (MPN) is expansion of myeloid lineage blood cells in the bone marrow and the peripheral blood. So what includes myeloid lineage blood cells? So let's see how hematopoietic stem cells will differentiate into different lineages. So the hematopoietic stem cell will differentiate either into the lymphoid lineage or to the myeloid lineage of cells. So the myeloid lineages include erythrocytes, granulocytes, which include neutrophils, basophils, and eosinophils, and also monocytes and megakaryocytes. So myeloproliferative neoplasms, expansion of these cells, the erythrocytes, the granulocytes, the monocytes, or the megakaryocytes in the bone marrow and in the peripheral blood. So what initiates myeloproliferative neoplasm? It is a single or multiple mutation in a single hematopoietic stem cell which will expand and proliferate in the bone marrow and will dominate the normal hematopoietic stem cells, which is due to hypersensitivity to growth factors. So this will lead to myeloproliferative neoplasm. These clonal cells may produce different cytokines and induce inflammation, especially the megakaryocytes and the monocytes, which leads to bone marrow inflammation and fibrosis and leading to extramedullary hematopoiesis, which is actually the main pathogenesis mechanism of primary myelofibrosis in myeloproliferative neoplasm. In general, myeloproliferative neoplasms can be classified into BCR-ABL positive and BCR-ABL negative myeloproliferative neoplasms. The BCR-ABL positive is chronic myeloid leukemia, which is SAML, and the BCR-ABL negatives include polycythemia vera, essential thrombocythemia, and primary myelofibrosis, which these are the more common ones from the BCR-ABL negative MPNs. So in this video we are going to discuss about the clinical manifestation, the pathogenesis, and the treatment of polycythemia vera, essential thrombocythemia, and primary myelofibrosis. The BCR-ABL negatives will have another genetic characteristics, which is the JAK2 Janus kinase 2, which is found mainly in polycythemia but also in essential thrombocythemia and primary myelofibrosis, and MPL, which is myeloproliferative leukemia protein, which is found in ET and PMF, and CLAR, which is CLAR reticulin gene, which would be found in ET and also in PMF. There is also called a triple negative myeloproliferative neoplasm, BCR-ABL negative and also triple negative. Actually, these kind of myeloproliferative neoplasms will have a poor prognosis. So the first will be polycythemia vera. By definition, it is markedly elevated red blood cell mass. And in the bone marrow, there will be pan-myeloid expansion. Pan means all of the myeloid lineage will be expanded. And it's due to ligand-independent colony growth. That means normally the JAK2 ligand, the JAK2 activation is ligand-mediated when there is only erythropoietin attachment to the receptor. But in polycythemia vera, even in the absence of EPO or erythropoietin, the ligand will get activated and proliferation and growth mechanisms will be stimulated. So there will be consistent activation and cell proliferation, which leads to markedly elevated pan-myeloid expansion. There are actually secondary causes of erythrocytosis which we need to rule out. It could be appropriate, that means in the presence of hypoxia, and inappropriate, which is in the absence of hypoxia. chronic lung disease, high altitude, hypoventilation, right to left shunt in the heart will lead to hypoxia and an increment in erythropoietin leading to erythrocytosis. But there are other causes, androgens, ectopic erythropoietin production, and renal tumors, which all may lead to secondary erythrocytosis in the absence of hypoxia. There is a WHO diagnostic criteria for polycythemia vera, and major and the minor. There are three major criteria, which includes hemoglobin of above 16.5 gram per day for male and greater than 16 gram per day for female, or hematocrit above 49 for male, above 48 for female, or red cell mass above 25% above the mean normal predicted value. That is the first major criteria. The second major criteria is bone marrow hypercellularity with pan-myelosis. All myelolineage cells will be expanded with bone marrow biopsy or aspiration. And the third major criteria is JAK2 mutation. It could be exon 12 or exon 14. And the minor criteria is serum EPO below normal. So to diagnose polycythemia vera, all the three majors or the first two majors and the single minor criteria, which is the EPO below normal, should be fulfilled. Clinical presentation, the symptoms, the patients would have fatigue, dyspnea, headache, visual changes, dizziness, vertigo, pruritus, erythromyalgia, thrombosis, epistaxis, or GI bleeding. The signs we may find splenomegaly, plethora in the face or in the extremities, systemic hypertension due to the hyperviscosity and increased blood volume, hepatomegaly, gout due to increased uric acid due to the loss of cells there will be dying and turnover, and cutaneous ulcers actually due to the ischemia. Complications of polycythemia vera, the main feared complication is thrombosis, which also occurs in 40 to 50% of patients with polycythemia vera, and it's common cause of cerebrovascular accident, DVT, pulmonary embolism, renal or portal vein thrombosis, and Burkieri syndrome. It is the most common cause of Burkieri syndrome is polycythemia vera. The other feared complication is, which occurs in long run actually, and is not common, like the thrombosis post-polycythemia myelofibrosis, which occurs in 15 to 20% at 15 years after diagnosis, and transformation of acute leukemia in some patients, 6% at 15 years of diagnosis. So risk stratification is for the complication. So patients with age of above 60 years or previous thrombosis, they are at high risk of thrombosis. And hemorrhage occurs when the patient is on antiplatelet and when they do have thrombocythemia. And acute leukemia, it could be treatment related, and reticulin deposition, which leads to myelofibrosis. So the treatment, the goal is to make the hematocrit 45% or below. So when it's above that, we need to do PRN phlebotomy, and all patients should be on aspirin unless there is contraindication, and anticoagulation in the setting of current thrombosis, and cytoreductive therapy for those patients who are at a very high risk of thrombosis. That includes age above 60 years and history of prior thrombosis. We can use hydroxyurea, interferon, or ruxolitinib, which is a JAK2 inhibitor, if hydroxyurea is intolerant or resistant. The next topic will be essential thrombocythemia. There is also a WHO diagnostic criteria. The majors and the minors, there are 4 majors, which include sustained platelet level above 450 million per ml, and bone marrow showing megakaryocytic hyperplasia, which is mature and enlarged, and not fulfilling WHO criteria for other myeloproliferative neoplasms, and mutations, including the JAK2, MPL, or CLAR mutations. And the minor is the presence of clonal marker or absence of reactive thrombocytosis. So to diagnose, all the four majors should be there, or the first three major and the minor should be there. There are also other secondary causes of thrombocytosis, which includes iron deficiency, infection, inflammation, connective tissue diseases, malignancy due to paraneoplastic mechanisms, cytokine mediated, and post-splenectomy or surgery, which is also stressful in inflammatory state. Clinical features: the first trimester spontaneous abortion, paresthesias, headache, visual change, dizziness, vertigo, erythromelalgia, thrombosis, which is actually more common in arterial than venous, epistaxis, GI bleeding, which is due to acquired von Willebrand's disease when platelet level is above 1.5 million per ml. The signs mainly splenomegaly and cutaneous ulcers. Risk stratification: patients may develop bleeding or thrombosis. So the high-risk patients in general are age above 60 and history of thromboembolism. All others can be considered as low-risk patients. So patients who have CLAR mutation are younger and thrombocytosis only and low thrombotic risk and better overall survival in patients with essential thrombocythemia. Treatment-wise, low risks, there is no need of platelet-lowering therapy, and the low-dose aspirin if no risk, increased risk of bleeding. For those with high risk, platelet-lowering agents and low-dose aspirin, same is like the low-risk ones if there is no increased risk of bleeding. Prognostic wise, in general, the overall survival is the same as general population when we manage and prevent thrombosis, and progression to AML in less than 5% of patients, and progression to myelofibrosis in less than 25% of patients. In general, ET has overall a good prognosis. The third one is myelofibrosis. It occurs due to clonal myeloproliferation, and there will be aberrantly secreted cytokines, which leads to fibroblast activation, which end up in reticulin deposition and bone marrow fibrosis in a sequential order. There will be increased circulating CD34 cells, extramedullary hematopoiesis, and primary or due to polycythemia vera or essential thrombocythemia. In general, patients will do have poor prognosis, and 20% actually progress to AML. The WHO criteria for the diagnosis of primary myelofibrosis includes three major criteria and the other minor criteria. The major criteria include megakaryocytic proliferation with reticulin deposition, which is grade 2 or 3, not meeting other WHO criteria for myeloproliferative neoplasms, and presence of mutations, and when triple negative clonal marker or absence of reactive myelofibrosis. The minor criteria include anemia not due to other conditions, leukocytosis above 11,000, palpable splenomegaly, LDH above the upper limit of normal, leukoerythroblastosis, which is peripheral nucleated red blood cells and mature white cells. So to diagnose all the three major and at least one minor should be there. The clinical features, the symptoms include non-specific B symptoms, weight loss, fever, sweating, fatigue, early satiety, abdominal pain, splenic infarction due to extramedullary hematopoiesis and huge spleen, and GI bleeding and bruising due to the thrombocytopenia. Splenomegaly occurs in 85 to 100% of patients, and others would have hepatomegaly, extramedullary hematopoiesis, cachexia, gout, portal hypertension, and ascites. There are poor prognostic signs for risk stratification, including anemia less than 10, transfusion-dependent patients, and thrombocytopenia less than 100,000, the leukocytes above 25,000, peripheral blood blast more than 1%, unfavorable karyotype, age greater than 60 years, and constitutional symptoms. All these are prognostic factors. Treatment-wise, it's based on the presence of prognostic factors, which is the risk stratification. When patients have prognostic signs, they will have be high-risk patients. They need treatment, hematopoietic stem cell transplantation if they are fit for that. If not, clinical trials. And for those who are low risk, and if they don't have symptoms, just observation. If they do have anemia, only manage anemia. If they have anemia and thrombocythemia, and the thrombocythemia is above 50,000, we use hydroxyurea to decrease the spleen size and symptoms. And if they same time do have thrombocytopenia, we will do splenectomy or splenic radiation based on the patient's agreement and other different factors. So if you get any important information in this video, please like, subscribe, and thank you for watching. We'll see you on next video.